Good afternoon, everyone. Kindly confirm that you can hear me. Someone confirm that you can hear me. Eric, can you hear me?
Yes, I confirm.
Okay.
Yes, I can hear you.
Thank you. So I want to take this opportunity to welcome all of you to this webinar. I see we have like quite a number of participants who have been able to join, and great. So first, as we are starting shortly. Of us this particular session, this is the session in level 1, the various community prayers champions who would like to get more and more information about TB. Basically, it's a sharing platform and would like also to get information from you. Feel free to use the chat box to ask any question that you may have. As we continue. So, and today's topic, we are going to discuss about TB prevention in Kenya, where we will be looking at community strategies for contact tracing and TB preventive therapy, and also how we support adherence, that is TB treatment interrupters tracing. So that's what we will be doing, and maybe to introduce the person who will be taking lead, the facilitator, our facilitator today. His name is James Mwangi. He is a sub-county TB coordinator from Murang'a County, with a lot of experience in implementing various TB interventions, all the way from diagnostic services to diagnostic services to treatment and follow-up of people with TB. He has expertise in all matters TB, and he will today be taking us through this topic. And AMREF Health Africa is you can unmute. Remember to register, know who is with us in this.
Mr. Mugai, I lost you at some point.
Yes, we can hear you, James, but you will need to put up one of the gadgets if you have two gadgets or someone is near you. Yeah. James, can you hear us? You are muted. James, you are muted.
Sorry for that technical issue. You can hear me confirm?
Yes. I can hear you now. I hope the audience can hear. Yes.
Thank you. And thank you once again
yes.
for that.
So you are.
I go ahead, Mr. Mugai?
Yes, go ahead.
Thank you for that again, once more for that introduction. And I'm going to discuss about TB preventive. I mean, the management of TB prevention, the community strategies that are there in our country, and as well as the contact management and regard to TB disease. This will be the outline of our discussion. We will talk about the situation of TB in our country. We'll also briefly talk about the TB transmission, some definition of terms that we need to understand so that when we start discussing about contact management, then we are on the same page when I refer to some terms. We'll also talk about contact management, the whole process, and why contact management, and as well as discuss about TB preventive therapy. So without, let's look briefly at the TB situation in our country. And Kenya is one of the countries that the WHO has categorized to have high burden of TB. as well as the TB HIV. And last year, we were able to notify slightly above 91,000 patients with TB against a global estimate of about 117,000. This represents about 78%. So we have quite a number of patients that we were unable to put on treatment because we were unable to reach them, or diagnosis was not made to them. And with the same estimate, about 24,000 patients also estimated to have been lost due to TB. And again, this is quite a significant number, representing about 21% of all the deaths estimated due to TB. Now, looking at the number of missing cases, we know that this is one of the areas where community transmission happens, and it is so defined that when you miss one patient in a whole year, you shall have, or that person shall have infected between 10 to 15 people. So contact screening is one of the high yield interventions for early TB identification and linkage to treatment. How is TB transmitted? Now, TB is spread from one person to the other through airborne. It's an airborne disease. When someone speaks, when someone talks, when someone sings, those that pray in loud voices, when someone is coughing, when someone is sneezing, all these are ways in which the bacteria are released into the environment. And when a healthy person again breathes these bacteria, then they go and settle into their lungs, where they are going to multiply and grow, and as well as cause the disease that we commonly call TB. Now, people with the TB disease are most likely to spread it to other people that they spend time with, and these germs, once it get into the lungs, sometimes other than causing that pulmonary disease or the disease confined to the lungs, sometimes it may pass to other parts of the body. It can pass through blood, sometimes through the natural passages, and others through the lymphatic system, and they may settle somewhere away from the lungs. So they may settle to the kidneys, may settle to the heart, may also settle to the spine, the bones. Think about the stomach, think about the reproductive system, sometimes the uterus, other times the fallopian tubes. Anywhere, we normally say that TB, there are only 3 places that it cannot infect. That includes the hair, the nails, and also the teeth. So this TB that is outside the lungs, we call it pulmonary disease. Now, looking at the transmission, we've already mentioned that the source is usually someone who has the TB in their lungs. So when this person coughs, when they sneeze, when they talk, any action that involves a phonation in the mouth, then they produce the bacillus, and those bacillus in a good environment, they are able to survive in air. And when someone who is healthy breathes these bacteria, then they lodge into the lungs, and where in the lungs now they multiply, and they start causing the disease. So, like I mentioned, let's talk about some definition of terms. When you talk about a TB infection, what do we mean? When you talk about the TB disease, what do we mean? And in this case, the infection, when someone inhales the bacteria, they go straight into the lungs. At this point, the individual has the TB bacteria in the body before it starts showing signs and symptoms. It means that in an immune competent person, we are able to arrest these bacteria in the lungs, and the state of the immunity putting or keeping in check these bacteria, that is what we call a TB infection. But the TB disease, on the other side, is when already now these bacteria, they start multiplying, and they start causing signs and symptoms of a disease that we call TB. So in TB disease, the person is sick, and they are going to have signs and symptoms of TB. So again, what is TPT, or TB preventive therapy? This will be the drugs that we give to any person who is at risk of getting the TB disease. So it means the person who had the TB infection before it now starts multiplying and giving the signs and symptoms, then we can treat that infection and prevent that person from getting the TB disease. Household contact, on the other side, we define this person as someone who have lived with or spent an extended time during the day or night with a person with the TB disease in the past 3 months before this person was put on TB treatment. Think about someone who spent a night or even 2 nights in a certain household, and this person had went there to maybe just visit, and that person had TB. So it's likely that during that contact, when they cough, when they talk, like we have said, it's likely that they may release some bacillus, and these bacteria, when the other members of the house would breathe in, it may start causing signs and symptoms of TB, meaning that this person has already infected the others, and they have now become or infected the TB disease. So this may mean, if you are looking, the period here is key and it's very important to look at the 3 months before the person was put on treatment. And also the other important aspect of this definition is the person whom have spent an extended time during the day or even at night. For instance, you end up having buddies. I'll give an example. The people who spend a lot of time in Miladens. These are the people that are going to spend quite a number of hours with a person. If, for instance, any of the members of that den were to ever get infected with the TB disease, then we are looking at all those people whom they have spent quite a number of hours with in those in that Meladen. And so when we are doing contact management, it is important to go beyond looking at just the household contacts and extend even to the social contacts that these index cases have interacted with. For again, those that may have spent, because we normally say they have spent a night, just one night, in the same enclosed household. If you look at during holidays, what happens, we have the school holidays, that is, we have quite a number of visits that happen. Maybe an auntie went to visit some family friends, a nephew, an uncle or something. And so when we are looking at the contacts we need to be careful as well as look at those contacts that may have spent even a night in the same enclosed setup in the past 3 months. Now, contact screening, on the other side, contact screening is a systematic way of evaluating a TB patient or evaluating for TB among people who are at close contact or a person with a bacteriologically confirmed TB case. So when these contacts, when we identify the contacts, then we need to look at them, evaluate them to know whether they have signs and symptoms of TB. If they don't have signs and symptoms of TB, then we can evaluate for eligibility to start them on TPT. Let's have a look at the difference between what a TB infection is and what a TB disease is. We've already mentioned that when an individual breathes in the bacteria, they go into the lungs. At that point, that person has no signs and symptoms, and that is what we refer to as a TB infection. So the TB infection, the Mycobacterium tuberculosis that causes TB disease, lives but does not multiply in the body. And by so, we mean that this bacteria does not cause symptoms. And again, this condition is not contagious, meaning it cannot be spread to another person. And the only thing that can happen is that this person or the TB infection can advance to an active TB disease if it's not treated. When you do an X-ray for this person, then you'll find that the X-ray is normal. There are no features that may suggest this person could be having TB. On the other side, if you look at TB disease, in this case, the mycobacterium is active and it is multiplying in the body. When it is active, it makes this person feel sick, and they have signs and symptoms that we normally say these are signs and symptoms of TB, including cough. Nowadays, we say just a cough of any duration, because if someone is coughing today because of TB, even if we wait 2 or 3 weeks to come, they will still be coughing because of that TB. So cough of any duration, we could be having fever, we could also be having some night sweats. Others could have other symptoms, chest pains, difficulty in breathing. All those the signs that may indicate that this person could be having TB. This disease, or the TB disease, is contagious, meaning again that it can be spread to other people, and if not treated, it can end up causing death. And when you do a chest X-ray, as one of the ways of investigating, you'll find features that are suggestive of TB. Allow me to talk about contact screening, now that we just mentioned about contact screening. And what we have mentioned is an evaluation of TB among those contacts of a person who has a pulmonary TB. And this pulmonary TB is what we call bacteriological confirmed. Bacteriological confirmed TB, it means that this person has been examined in the laboratory and they have been found to have bacteria that causes TB. So it could either be they have been diagnosed through GeneXpert, or there is a smear microscopy that has been done in the laboratory, and this has detected the bacteria, and this is what we refer to as a bacteriologically confirmed TB case. So what do we want to achieve when we do contact tracing? One is early diagnosis and treatment of people with the TB, because we know that a person who is a close contact with a bacteriologically confirmed TB case, they have up to 7 times more chances of getting TB. And so if we go and do contact tracing early, then we are able to get all those that could have TB from the same index case. And when you treat them early, again, they get cured early, you get them better, and they also have better outcomes for treatment. The other reason is that we want to identify all those that have a TB infection. A TB infection, that is what formerly we used to call latent TB, and evaluate them for TPT. And the last reason, we want to reduce further transmission of TB, because it's only those that have TB that can infect another person with TB. Contact screening in our setup, we do it in two ways. We can either do contact invitation or contact tracing. And a contact invitation, this is when a healthcare worker invites the contacts to a health facility, and the screening will be done by the healthcare worker. On the other hand, for contact tracing, we invite the CHPs that go to visit the household, and they do the screening for the contacts at the household level, then we refer all of them to the facility for further evaluation. Now let's look at the process of contact screening in a more detailed manner. And like we just mentioned, that there are two ways in which we can do contact management. That is contact screening, either through contact invitation or contact tracing. And the contact invitation, we have said, is what is done by the healthcare workers. This is the preferred method, because even when we do contact tracing, the CHPs, again, they are going to send the same patients to a health facility for another contact management or contact screening to be done. Now, allow me, this slide is a bit busy, but I will go through it and describe this process in detail. Because at the facility level, when a patient comes, they are recorded in a register we call TB4 register. This is the TB register where all the patients that are taking drugs are entered. So a healthcare worker is going to identify those that are eligible for contact screening. And the ones that are eligible for contact screening, you said they are the bacteriologically confirmed TB cases. In this, at this point, I'm also going to add that all children that are below 5 years of age, we also do contact screening for them. And this is called reverse contact screening, because children below the age of 5 years, they normally, most of the times, they are with their caregivers, their parents, and they will get a TB from an adult source. So the reason why we want to go and do contact screening for children below the age of 5 is to identify who among those that are staying close to this child may have given this child the TB disease. So after the healthcare worker identifies those that are eligible to be done contact screening, then they take a history of the households and do what you call line listing, or putting them in the contact management register. The contact management register the setup is, and I know most of us have interacted with this register, is the green register in our health facilities. The healthcare worker again will determine if they need to do contact screening or contact tracing or contact invitation. When they have talked with the client, and if the client is not comfortable to be visited in their homestead, then he is going to do contact invitation. But let's look at the contact tracing. If the client is comfortable that contact tracing can be done to their homestead, then the healthcare worker is going to assign a CHP that will go to those households to do a contact screening. But before the CHP goes to the household level, they need to have a plan with the client or the index patient when to visit, so that when they eventually agree on a date to go and visit, then all the contacts that were line listed in the contact management register, they will be available for screening. So at the household level, the CHP will do two things. One, they are going to do health education. Health education will involve talking to all the contacts, including even the index patient himself or herself. Talk about the TB disease, how it is spread, ways of prevention, and two, they're going to do contact screening as for each and every individual that has been in contact with this person. When they do contact screening, the findings are entered into documents. One of the documents they are entered is the screening form, contact screening form that the CHPs normally fill. And then we have the tubulite. So the contact management or the contact screening is done, or most of the times done through tubulite. And this is what we would want to advocate. When you go to the health or to homesteads, using the tubulite to contact screen or to do the screening becomes easier, even when you want to update the activities that have been done on this client later. So as CHP then is going to refer all the contacts to the health facility using the MOH 100 for further evaluation. And note here that it is all the contacts, regardless whether they have signs and symptoms or not. So back to the facility, the contacts that were referred from the community will be evaluated by the healthcare worker, and the outcome of those that evaluation is going to be updated in the contact management register. So that evaluation involves two things. One, it's screening to see whether this person has TB. And if they have TB, then they are started on TB management. If they don't have TB, then they will be managed for TB infection, which means they need to be given TPT. So there are two registers that need to be recorded or need to be registered here. We have a TB4 for those that are, and TB4 is the yellow register for TB. For those that will be found to have TB, then they will be put on TB4. For those that do not have TB, and they need to be put in the contact management register for TPT. So here, the CHP will also need to follow up at the facility to update the outcome of contact screening in the contact screening form. The other thing I must say here that the CHP also needs to follow up is to ensure that if there was any outcome that was the outcome of evaluation that had TB, then ensure that or ask the healthcare worker whether that case has been assigned to the CHP as the source of the patient. Finally, contact screening forms, they are approved by either the chair. In our setup, it's both the chair and the sub-county TB and leprosy coordinator and submitted to the sub-recipient for payment. Let's again look at contact invitation. When the healthcare worker, after entering the patient, they reach the patient in the contact management register and line listing, then they decide whether contact invitation or contact tracing is going to be done. If in this case is the contact invitation, then the healthcare worker will plan with the patient to bring the household members or the contact to the health facility for TB screening, testing, as well as initiation of TBT. So during the time that this client or the IDEX patient comes with the contact, the healthcare worker is going to provide health education. We're also going to do screening and also evaluate contact and update the findings and the outcome in the contact management register. The contacts that will be found to have TB will be initiated on treatment, and the contacts that will be found not to have TB will be assessed for TPT eligibility and initiated on TPT. The screening outcomes of and the TPT initiation, they are documented in contact management register, as well as in the TB for those facilities that have TB in place. So again here, the healthcare worker will fill the contact invitation, transport reimbursement form that is available from the SRs. When it's signed by the IDEX patient, and the healthcare worker is going to do the verification. And finally, the SR will visit the facility to verify whether work was done, correct the forms for payment, and process the payment. So briefly, that's how either contact tracing or contact invitation happens in our various facilities. Allow me to now talk about TPT, the TB preventive therapy. And you know, as we mentioned earlier, this is the treatment that is offered to anyone who is considered at risk of developing the TB disease. And the simple reason is that we want to cure the TB infection that they may be having. And so therefore, when you do that, you are reducing the risk of developing the TB disease, and as well as ridding the community of the bacteria or the TB bacteria that may spread within the community. This, before the initiation of TPT, you need to ensure that all those that are eligible to take TPT, they are screened and evaluated to rule out the TB disease. The screening is through a qualified healthcare worker that does symptomatic screening, what we have mentioned as a systematic way of evaluating patients, as well as instituting all the investigative measures to be able to rule out the TB disease. So persons that screen negative for TB and they have been evaluated and TB is ruled out and are eligible to be put on TPT, then they are initiated in the appropriate TPT regimen. Now, let's compare some data here of TPT that was done or how our performance have been nationally for the 2 years. And these figures, you can see that the household contacts represent the bulk of the patients that we put on TPT. followed closely by the healthcare workers. Healthcare workers, they are at risk of developing TB, prisoners and prison staffs, and as well as those with other clinical risk groups, including patients who have conditions like silicosis, others that have been on treatment for cancer, others that have been on treatment for dialysis, and the 2 years with a slight improvement from 2024. We put a combined, in 2025, that first year, a combined total number of 63,435. And this is about a 40% increase. And so when we want to think about eradicating TB, remember anyone who has a TB infection, we potentially say this is a person who can get TB. And TB can only be transmitted from those that have TB. And so as one of the milestones of ensuring that we fight TB is to put patients on the TB preventive therapy. Now, these are the available options, or the TPT options. We have a drug that we call rifampicin, and it's taken rifampicin, isoniazid rifampicin, and we give this drug for 3 months. It is taken once per week. So if today is Tuesday and someone starts the 3HP today, then they will take another one in the next Tuesday and another one the other Tuesday, for a total of 12 times. That is 3 months. So this drug is given to all persons above or equal to 12 years, both HIV positive and HIV negative. And so the country also is in the roadmap to implementing TPT to all age group when we have the correct or the available molecules for those below 15 years. So the other regimen is what we call 3RH, 3 here representing the months. So these are 3 months of rifampicin and isoniazid. It's taken daily for those that are HIV negative, children below the age of 15 years. So we give them rifampicin isoniazid daily according to their weight for a period of 3 months. The last option we have here, and these options, they are for drug-sensitive TB. The last option is for 6 months of isoniazid. And again, this is given daily to all those that may be HIV positive, children and adolescents who are less than 15 years. This drug is also given to those that are pregnant and those who cannot be able to take the other regimen for one reason or another. Maybe they have reacted to the drug or they cannot tolerate the other regimen. So how do we do follow-up for clients on TPT? The clients that should be or that are put on TPT, first they should be educated on TPT. They need to understand why do we need to take TPT? And the simple reason, we have said we have a TB infection. And that is the infection that we want to eradicate. They also need to understand the signs and symptoms of TB. They need to understand the side effects of the drug, so that when they start taking the medication and they find signs and symptoms or a particular effect of the drug, then they can report immediately to the health facility for to be assisted. So if they develop signs and symptoms in the course of TPT, then they should be referred to the health facility for further evaluation. And in the community, direct observed treatment should be provided to the client so as to enhance adherence, to ensure that these clients are able to complete their treatment and they don't have the TB infection. The person on TPT, they will be required to visit the health facility for assessment after completion of TPT to ensure that they do not have the TB or any side effect of the drugs. We give them appointment when they will come to the health facility for further evaluation at completion at 3 months, at 6 months, as well as 1 year following the TPT completion. And the role of the community players in contact tracing, we need to look at some of these roles that we as the community players play in matters of contact tracing and also matters of TPT provision. One of the roles that community players play, and key and very important role, is sensitizing the community on contact screening and the need to take TPT. Then another role is identifying those that are at risk of TB in order for them to benefit from TPT. They also conduct symptomatic screening of at-risk population, then referring them and linking them to the health facility for further evaluation. This is just what we have what we have already discussed. And the other key important role is to provide DOT support. DOT meaning direct observed treatment to clients who are initiated on TPT. So let's remember again, it's also a role that for those, after we have done contact tracing and the client have been put on TPT, it's also our role to follow them up to ensure that they are taking the drug as prescribed. Follow up clients initiated on TPT to ensure again they complete their treatment, and as well as report to the facility if there are any challenges that these clients are facing when they are on TPT. It's also our role to address any myths and misconceptions about TB and TPT in the community, and also address the key barrier to the success of TB treatment, that is stigma and discrimination in the community. Now, let's look at treatment adherence and also how we do tracing for the interrupters. TB drugs, for those that have been found to have TB, they are supposed to be taken in their correct doses and as well as appropriate time and for the prescribed duration of time. Now we know that TB disease in our country currently, for drug-sensitive TB, we are treating that TB for 6 months and 12 months for those that have TB of the spine or TB of the bones, and those that have TB of the meninges, what we call TB meningitis. So adherence to TB treatment will be key for the good outcome and in order to be able to curb the transmission of the TB disease. These clients who are on TB treatment, they need support in order to ensure that they have a good adherence. This support should come from the family members and also the community. We need to provide the necessary emotional and psychological support to ensure that they are able to complete their treatment and also adhere to the timelines and visits that are prescribed by their attending clinician. So DOT for people on TB treatment is recommended An adult mentioned is a direct observed treatment. This can be given by a family member who observe this client taking drugs, or by a community player, either CHP or TB champion or any other community player of interest. The patient who missed a scheduled TB treatment appointment must be traced promptly and returned back to treatment. This is how we do it. And for definition, the treatment interrupter is any person who misses a scheduled visit. And treatment interruption tracing means is the process of identifying and locating this patient who have missed drug correction during their clinic appointment. So why is it important? One, it is going to help the patient understand the importance of adherence and resume to treatment. It's also important to reduce emergence of multi-drug resistance TB, because when a patient is not taking the drugs as prescribed, then the possibility of the bacteria resisting to the drugs they are taking is very high. Then we also, the other important is to reduce transmission and the spread of TB, thus helping to control this disease. Finally, is to increase treatment success rate and reduce morbidity and mortality. So what are some of the reasons why patients interrupt or they fail to take their treatment as prescribed? One could be long distance to treatment. We have patients that go to very long distances to get their treatment because there is probably no TB treatment site that is near them. And of course, the long duration of treatment, we end up getting tired from taking the medication. Adverse effects of the drugs. There are those patients who may feel that when they take the drugs, they start having or feeling worse than they were before. And quite a number of them will stop taking drugs because it's giving them side effects. The other reason is the lack of adequate health education. And health education, normally we say it's not a one-day thing. We need to continuously offer health education to the patients when they come to our facility, or any opportunity we have to talk to the patient. Lack of support from community and family and friends. It has also been one of the reasons why a patient may interrupt. And at times, even us, the healthcare facilities, when we have negative attitude towards our patients, stigmatizing them, then it's also some of the reasons why this patient may interrupt their treatment. Quite a number of patients have described food insecurity as one of the ways or the reasons why they stop taking their drugs, because they don't have food to take. We have also other patients who are on drug and substance abuse, including alcohol and other hard drugs. Stigma and discrimination, it's also one of the barriers to a successful treatment. And appeal burden. We have quite those patients that may be taking very many drugs. If, for instance, they have other conditions that also require them to take their drugs. Let's say, for instance, they also have diabetes, or they could be having their hypertension or HIV, and they are taking other drugs. So again, here you come and add TB drugs. So this adds to the burden, and some of the patients stop taking their drugs because they feel that they are taking too many drugs. Occurrence of disasters like what we are having in our country, the floods, some people have been displaced. by the floods that have happened. And so one of the reasons why they stopped coming to the clinic or stopped taking their medication because of that displacement. How do we prevent treatment interruption? One, continuous health education. Like I mentioned, it's not a one-day thing. We need to continue talking to our clients, talking to our patients about the importance of completing their treatment and offering direct observed treatment. In advent of the technology, nowadays, I've seen direct observed treatment happening through technology. Patients just take a video when they are taking their drugs, and support is, or the person offering support, even though far away from the patient, they are able to observe their patient take their drugs. Nutritional support was one of the things that we mentioned is food insecurity. And of course, decentralizing TB services to bring them nearer to where the patients are, so that they are not moving very far distances to collect their drug. Support groups, they are key and very important in order to provide that psychosocial support to the patient as they continue taking their drugs. Who can do, who can trace patients or those who have interacted? This is done by anyone who is in contact with this patient can do help, treatment interrupt, or tracing for treatment interruption. But for us here, we're going to address ourselves to community health promoters as well as TB champions. The key in ensuring that we are able to put our patients who have interrupted treatment back to treatment. So the process goes the same way that we talked about contact tracing. The healthcare worker, the facility, they are going to identify those who have not reported to their clinic through the TB4 register and also looking at the appointment diary. So that when they identify a particular patient has not honored the appointment, then a phone call is done and the appointment is rescheduled. If the patient does not report during that rescheduled visit, then a physical tracing is done by the CHPs and or the community health actors, or for those who were not reached through phone after 24 hours, then a physical tracing is going to be done. It is key and important to start physical tracing early so that we are able to return our patients back to treatment so that the infection does not spread, or we are able to put them back to treatment without much delay. So when the CSP goes to the facility, they correct the details of the patient who have defaulted or have interrupted their treatment. They also identify or collect the locator information provided in the registers, and they go to the households to do the tracing. At the household level, a CHP is going to find out the reason for this patient interrupting treatment. And health education needs to be provided at this point, reinforce the past health education that, or the preceding health education that have been done on this patient, and then refer them back to the facility for continuity of treatment. And referral need to happen through MOH 100 form. So that is all I had to discuss, and back to you, Mr. Mugai.
Thank you. Thank you very much, James. for taking us through that presentation and bringing us information on the various areas that we need to. He was able to take us through contact screening and a very good background that he brought to us on how TB transmission occurs, and so that we can understand why we are doing contact screening, how we have a person with a TB infection. They are not sick, but they have the TB bacteria in their lungs. Then TB disease, which is now the sick person, all the way to how the processes that we follow when we are doing contact screening, and why we do this contact screening. And as I speak like this, I would like to welcome any questions, any concern, and I propose that you write these questions on the chat box so that our facilitators and the panelists who are there can be able to address your questions. If you have any question on contact tracing, any question on treatment interrupters tracing, please put it up there. I will be able to read it, and you will be answered. And there is the first question here, James, asking, can someone who has missed TB treatment for a week be termed as treatment interrupter? So can someone who has missed TB treatment for a week be termed as treatment interrupter? Maybe as you answer that, you can also address a question of timelines of maybe if I have missed treatment for only 2 days, what happens to me? If I have missed for a month, what will happen to me when I come back? Maybe you can address that as we wait if there is anyone else with a question. Kindly address those ones.
Okay, thank you, Mr. Mungai. Someone is asking, can someone who has missed TB treatment for a week be termed as a treatment interrupter? The treatment interrupter, if I may go back slightly, it means someone who has missed an appointment. So if today was their appointment and they didn't attend, that is someone who has missed, or that can be termed as treatment interrupter, regardless of whether they missed that that appointment because they had drugs or not. So it's when the CHP or the community health actor goes to the facility, to the household level, determines that this patient actually missed the appointment because they had some extra drugs that they took from another place. So at any time, if they have failed to honor their appointment, then they are termed as treatment interrupters, and so we need to initiate a treatment interruption or tracing for treatment interruption. For the timelines, as Mugai, you have rightfully put it, if a patient, this we categorize depending on the phase in which the patient is on in their treatment. So we have two phases. We have the intensive phase and also the continuation phase. The first 2 months, we term them as intensive phase. And if a patient misses drugs in the first, depending in the intensive phase, depending on when they had taken their drugs, then the healthcare worker is going to decide whether this person needs to be restarted on treatment, or we are going to extend the number of days that this patient has missed. And similarly, the same way in the continuation phase. So depending on the number of days that this person has missed their drugs, And here we talk in terms of when or how much time has this patient taken in the continuation phase, and how much time have they missed their drugs. But the key and the important thing for us to understand here is that if a patient has missed their drugs, then let them be guided by the healthcare worker at their facility, the number of what needs to be done. One of the things that we do is we are going to do a sputum assessment, or look at the sputum to be able to determine whether they have bacillus in their sputum or they don't have. If they have, and depending on the number of days that they missed, then that person can be or will be restarted again on treatment. So at this point, I want to say that it will depend on the phase at which this patient was in their treatment, the number of days or months or weeks when they had taken their drugs, and the outcome of TB assessment, that is sputum assessment.
Okay. So thank you.
Yes, John.
Yes,
Continue.
go on.
Yes,
okay.
I've seen some other questions. Allow me.
Yes, there is yes, go on. There is a question here about at what point do we initiate reverse screening? So you can talk about that briefly. Reverse contact tracing.
Thank you, Mongai. And reverse screening, or we call it reverse contact screening. We mentioned that children who are below 5 years, they get TB from an adult source. So if you have a child who has TB, it means someone close to them have TB, either from their caregivers or their parents, whoever. And remember, again, we mentioned about a contact being someone whom have spent a night in the same enclosed setup 3 months before the treatment was started, or they spent extended number of hours together. So here, reverse contact tracing means this child has been put on TB treatment. Then we go back to look at among the contacts who have had interaction with this child, who is it that was having TB? So it could be a house help, it could be some of the parents who came to do or to see the child when this child was born, or anyone. So that is what reverse contact screening is. When it should be done, just immediate. The point that we get this child with the TB, then it is immediate. I go ahead.
So thank you. Thank you very much. Sorry. Yeah, you will go ahead. Maybe to add on what he has said. So for maybe to add that for reverse contact tracing, immediately you get a child below the age of 5 who has been diagnosed with TB. We know that children below the age of 5 will spend most of their time at home. Even if some of them go to school, they go to school briefly and come back home. So the best place to look for the person who infected this child with TB will be at home. And that is why we are saying that can we go to the home of this child and screen all the family members for TB to try identify the adult who transmitted TB. So now Peter, James, sorry, there is another question there. There is this question. There is one question that is not clear. Someone asking if you can briefly repeat on TB transmission. I don't know whether we do not have time to repeat that. Maybe unless you mentioned in passing. But maybe as you address this other one, there is a long question. This is someone called Joyce McKenna, TB James. I have a zeal to see that TB can actually aid and have zero infection. I have two questions. In the global fight against tuberculosis, how can health system balance the need for strict treatment adherence with culturally sensitive, patient-centered approaches, especially in poor settings where stigma and economic barriers remain significant? That is the question that has been asked. And really, James, I think what you need to comment about this is that we have the TB drug that has certain demands. The demands are for the drug itself, that demands that you have to take me every day, this number of tablets, this time for a period of 6 months. You must take the drug, and otherwise there will be consequences. There will be resistance, there will be poor outcomes. So how do you balance this and the day-to-day life where we face real life situation where maybe I'm not able to take the drug because I don't have food? What do you say about that, James?
Okay, thank you, Mugai, and thank you to our participants for those questions. If I just briefly talk about TB transmission, just note that when someone has TB, they produce the TB bacillus to the environment, and when these bacillus in the environment gets to someone who doesn't, or a healthy person, they breathe in those bacillus, goes to the lungs. In the lungs, if we have immune competency, for those that their immunity is good, then it is held in the lungs at that point. So if the immunity goes down, then the bacteria start multiplying and causing the TB disease. So it starts from someone who has the TB disease, then goes to a susceptible host. I think briefly that's what I may say. Now, for the other question from McKenna, and thank you for that comment. I think, like you've just put it, we need to, even in our policies, as we continue addressing TB menace in our country, we must be able to offer health education to our patients. They need to understand that TB is treatable, it can be prevented, but if it's not treated, then we are facing a problem or a challenge of death and mortality. Sometimes our TB patients also heal with what we call complications. So we end up having someone with what we call post-TB disease. So when we give the correct information the patients need to understand, then make an informed decision. As in making an informed decision, then you also need to understand that in our country, TB is a disease of public health importance. However, we know that stigma and discrimination is one of the major barriers to effective TB treatment. And one of the things that we are doing in our country is going to the community level. We are actually going the primary healthcare way in terms of TB treatment, involving the peers and involving the community health actors in TB management. So at times you'll find areas where TB treatment is taken to the lowermost level of healthcare management, that is at the community level, in order to be able to mitigate some of the issues that are affecting the TB management and the TB, the success of TB treatment, including establishing of support groups, so that patients are able to, address the issues that they have, the fears that they have, and so that we can be able to manage every patient individually as they present. So that's what I may say, John.
Yeah, so thank you for that. And McKenna, we also take note of your passion to touch people who have TB, and that is very good. And we encourage all the champions who are here, and all people, all members of public who are here to make their contributions to helping people who may be suffering with TB. And your small contribution, your small support that you can give can go a long way. And maybe also to add on to what else are we doing to help the patient in this journey. Other things that we are doing also, or the TB program is doing together with the partners, is also to explore on maybe friendly drug regimen that are maybe taken for shorter period. Like I am sure you have seen that in treatment of drug-resistant TB, so that we can help the patient as they walk this journey. And moving forward, there is a question by Magdalene Katua from Machakos. What do I do if the person completely gives up hope? So this is someone who have given up hope. They are no longer, they don't want to take the drugs again. Because of maybe maybe the drug challenges they are faced with the drug, or any other reason. So what would someone do to help this person? James, are you there?
Yes, John. If someone someone asked if someone just wants to die, one of the things that we normally say about TB and TB and other chronic diseases is that there is an aspect of mental health that is involved in this. So when one is diagnosed with a chronic disease, we've seen even patients who, whenever they are told that they have TB, then they break down and start crying. So one of the things, or the ways that I usually ensure that our patients I have is a mental health assessment as well as interventions. So these people need to be attached to a counselor. And I want to address that question to someone who has said, what do you do when contacts, they don't want to be screened? It's the same way that they need management, mental health management, including health education. We need to continue talking to them until they are able to understand the problem they may be having. So we say that TB is curable. That is a very key and very important message that we need to pass to our client and our patients, that they don't look at TB as the end to their life. The other thing that we need to tell our patient is that when you have TB, it does not equal to having HIV. We know in our country, the prevalence survey told us that majority of our patients, actually more than 70% of our patients, are HIV negative. So it doesn't mean, because I know that has been one of the areas where patients feel when they are diagnosed with TB that they also have HIV. So those are key messages that we need to address and pass to the patient. But more importantly, let's link them to a mental health specialist so that they are able to get help they require. Briefly, John, someone asked whether TPT, they can, after finishing TB treatment, when does one start TPT? And I would say it's immediate. Following successful TB treatment, TPT can be initiated immediately. Back to you, John.
Okay, thank you. Maybe to add on the question of the patient who is not, of the person who is giving up on using drugs. Yes, we need to support this patient. We need to offer all the support, counseling, psychosocial support, and everything so that they take the drug. Then, on the other hand, remember, TB is a public health disease where when I have TB, it will affect other people. I will transmit to other people, and therefore I am required to take the medication. And there is a provision where the patient can be admitted in a hospital in the isolation unit from where they can be supported to take the medication. Then maybe our time is running. There is, oh yeah, you have answered the question on contact tracing. There is this question about after how long is after taking TPT, after as a healthcare worker, after how long do I need to I think you answered that. You answered that question. Oh yeah, after finishing, did you answer that? James, the repeat for repeat dose of TPT for healthcare workers. Yes, James?
Sorry, John, did I hear you? I missed that.
Yes. Is there a guideline on when to repeat TPT as a healthcare worker? If I take TPT today, when do I take again after I finish?
Oh, okay. Thank you. I thought I answered about the end of the TB drugs, but for TPT in our country, it's once. We take once.
Yeah.
TPT. So there is no policy where you repeat TPT.
Thank you very much. So let me go to this question. I'm Jacqueline Mwangi from Wansingishu, and this is my concern. When a person screen negative but still has some symptoms, what is the recommended follow-up action at the community level? Maybe I can take this to help James to take a breather. So this is a person who has TB symptom or TB-like symptom. We have done everything and all the tests are negative. And every clinical, even clinically, the doctor doesn't think that I should take TB treatment. Now, this is a patient who is supposed to be evaluated for other diseases. Remember, apart from TB, we have a whole lot of lung diseases. We have a whole lot of other lung diseases, and this is a patient who should be evaluated for that. However, remember also that if my tests are negative, the test gene expert is negative, the clinician always have a room to decide whether they are still convinced. There is the room for clinical diagnosis. So we can have a few patients who have tested negative, but they still get treated for TB. But if the clinician don't think that it's TB, I should be investigated for other diseases. So there is this, you take it, James, you can take it briefly, quick answers. What happens to a person who interrupts treatment for more than 2 times? That is question from Agnes Sigano.
Well, interrupting treatment, I'm thinking if it is a TB treatment, TB treatment needs to be taken up to the last dose, because that's the only way you're going to get cured. But if it's TPT, now TPT, there are those that we say after unsuccessfully being able to address the barriers to adherence, then we stop giving that person or that client TPT. But for TB treatment, we need to involve a multidisciplinary team, including the family members and including the community health actors. Sometimes we also include the administration, provincial administration, to be able to put the patient on treatment. Remember, I said that TB is a disease of public health importance. So if someone is not taking their drugs, then we go into other measures that are going to ensure that we put the patient on TB treatment. So at this point, I normally advise people to link with the public health department in their respective areas. And this, they are going to assist us, and they have actually been assisting us put the patient who have refused to take their medication to completion. Yes.
Okay. Thank you. So as James prepare yourself to take this question quickly as I take this one, can a patient adhere to medication up to the last day, I believe, and test positive again? Then I take this. What is the relationship between anti-TB and alcohol when the client is taking both? So that is from Joseph. Joseph, these drugs that people take, the TB drugs, remember they have to be cleared from the body through the liver, through the kidney. And if someone is also taking other drugs, other substances, it means that they are overworking their system. And for especially for a person taking alcohol and TB drugs at the same time, they are likely to start getting liver problems, some liver problem or other problems with the body organs. Also remember, alcohol will make them not adhere to treatment and all that, and we are going to have those challenges. Maybe now, James, take the other one quickly. Then as we close the meeting, we are 2 minutes to time.
Yes, thank you, John. Yes, someone can take their drugs, they adhere very well, and to the last time, and when they test, the test is done, is also positive. Two scenarios. One, and I would want to understand what test was done, because if it is a gene expert that was done, gene expert may continue being positive even after that person has completed their treatment. Gene expert is a molecular test, so it takes the DNA, even the bacteria that is dead be picked up by that test. And if it is smear positive, or in the lab we do a smear microscopy and it is positive, then that means that the patient has failed their treatment. Sorry, back to you, John.
Okay, thank you. Now the last question. Hello, I am Anastasia from Nairobi County. I have to add this point. What another gap? Oh, sorry. Another gap that we are facing as a country surrounding TB is the interruption and loss to follow-up for the alcoholic and the drug abuser. This is one major factor we really need to address. Thank you very much, Anastasia. We will be able to, as we work with TB program and the county and the community, we'll be able to address these gaps. Then there is the person who has been tested over and over again, and they have TB symptoms, but the tests are negative. They need to be evaluated, and the clinician can be able to make a decision about that patient. So that person. So we have come to the end of this webinar, and I want to appreciate each one of you for coming to this webinar. James, special appreciation to you and the team that set up this. So thank you very much. So asanteni sana, and we have come to the end of the webinar. So kwaherini sana, and God bless you. Thank you very much. Bye-bye.
Thank you. Bye.